So I'm going to talk about in-office procedures and the scope of practice. I have no relevant disclosures. Here's the learning outcomes I thought we might accomplish. Ryan did some AI objectives for me. And I said, did you extend my time? Because this is a lot, but I'm going to try to see what I can do to cover these today. But this is a list I saw recently on something that came out of the Men's Health email blast that comes every week, celebrating APP Week, saying here are all the potential procedures that APPs might participate in, and I'm sure there are actually some more. Every time I thought I had the list done, I found something else to add on. The last one I added on was OR First Assist. I thought of that the other day. So APPs can do a lot of procedures, office procedures, or actually even help in the OR. The question is, in your practice or in our practice, what's the best fit for us? I'll use cystoscopy as a model for this, but all procedures I think you could think about the same way. In 20 states and in DC, NPs are allowed to practice independently. Virginia has autonomous practice now. North Carolina does not. 17 have a collaborative practice. North Carolina is still a collaborative practice. I did talk to Lise before this meeting, and that's continuing to be looked at to see when that might change in North Carolina. Scope of practice needs to be clear and based on educational background, clinical expertise, and collaborative relationship with the physician. Communication is paramount. Here's a quote from the AUA census. The APP in urology is a physician-led team. Team-based care plan may be part of the solution. It's estimated that in 2035, the use of APPs in urology will nearly double in the U.S., while practicing urologists will decline. So we have to figure this relationship out. I think procedures is one way to think about it. So again, here's North Carolina. Physicians associates also require a collaborative practice agreement. There have been attempts at legislation for full practice authority, which are ongoing. There is a bill pending on optimal team practice right now in North Carolina. Virginia has the option of full practice authority if you have more than 5 years of clinical practice and you submit a request. You have to have physician support, documentation of your practice and your ability to practice independently. So here's from the AUA 23 update, although I will tell you I looked at some of this data. It's still based on old data. The AUA is thinking about it's time to reassess through the new census our white paper on APPs in urology. But APPs can meet up to 70% of patients' needs in the primary care setting if allowed to practice at the top of their license. So APPs in urology workforce, 70% of practicing urologists work with one or more nurse practitioner or physician assistant. APPs, according to the 17 data, in comparison to 2015, that number was already up. We know that number is up again. I heard someone, I think maybe Ryan said 77%. We know that number's climbing. 1/4 of APPs in urology independently perform cystoscopy for stent removal, neuromodulation, for InterStim programming, priapism injections. You saw the list that I gave you earlier. The 2017 urology practice article, which is still being quoted, if you go back and if you Google this, you're still going to get pushed back to the 2017, 2018 data, but found that they did 54,000 simple procedures in 2003 versus 230 in 2017. So think about that. The numbers are growing, so I think the trick is to figure out how to fit that into your practice appropriately. The census in 2020 said 1 in 5 APPs assist urologists in performing cystoscopy for difficult catheter placement and stent removal. I work in the ambulatory setting. We have a nurse practitioner in our group that is an inpatient nurse practitioner, and she does all of our difficult catheter placements as part of our team and through the ER, and also she does stent removals for our transplant patients who somehow miss their appointment in the clinic because they're admitted and need a stent removed. So we have trained her how to do cystoscopy with stent removal with disposable scopes, and we do those in-house if necessary. It's not our pattern, but we certainly have the ability and a trained APP to do that. So office cystoscopy, one of the most commonly performed urologic procedures. Expansion in cystoscopy with APPs has really been growing, 10,000% increase in the last 20 years. High levels of patient satisfaction with decreased wait time for surveillance cystoscopy. We'll talk about that in a moment. And the quality and financial implications in multiple countries in Europe have shown nurse practitioners were observed to provide equivalent services in terms of cystoscopy. So the boundaries between APPs, either NP or PA, and MD practice continue to blend based on local patient-centered and guideline best practice documents. Multiple traditionally medical practice are taken up and shared by professions such as APPs and PA, and a national precedent exists for training and utilization of APPs and NPs in cystoscopy. So it is not a historic component of training in NP or PA practice necessarily in your educational preparation. The origins of NPs performing cystoscopy is actually from the United Kingdom. They do not now have as many being done by APPs percent-wise, but in fact they wrote the original curriculum for training. The BAUN group did that, and they still use NPs for bladder cancer screening and surveillance as well as stent removal. So NP education, the barriers to role expansion include a lack of standardized curriculum. So we talked about this over dinner last night. If you're going to have an APP join your practice, you have to decide what kind of investment you're going to make in that APP, how you're going to train them, what you want them to be able to do, but also how can you get them credentialed in your system. We have a credentialing system where if you're going to add a skill on, you have to do some didactic and some observation of that skill, be supervised in learning how to perform that skill, perform some on your own with supervision available close by, and then eventually submit that documentation so you're credentialed to do that procedure independently. SUNA, the Society of Urologic Nurses, has a position paper supporting adding cystoscopy to the NP skill mix. Here's their position paper. You can look it up online, but they basically talk about the increased supply of nurse practitioners, and they're looking at nurse practitioners, but we can also, I think, include PAs in this sentiment. Oh, sorry, now I don't know how to go back. Somebody help me. Here we go. Can I go previous? I clicked way too fast, sorry. All right, so this is from, again, the AUA, and from their white paper looking at clinical urology environments where APPs are valuable, appropriate mentorship and training. I think this is the key to success. We've heard a lot today about how are you successful. I like one of the things that Ryan said earlier. If you are successful, you get some feedback on your performance, you actually feel more confident, you're going to actually be more successful. I had a bad day in clinic the other day, had a very difficult cystoscopy for a stent removal with a young female transplant patient. Really blew me. I finally successfully did it, walked out of the room and thought, okay, I made it through that. It took me a few minutes to get ready to go in and do the next one. And my MA was like, come on, you got this. And I was like, yeah, but I got to recover from that. That was not pretty. So you do have to have confidence when you go in, and giving that APP the support they need so they will feel confident to do that procedure is very important if you want them to be part of the team in your practice. And I really think it's about having them as a team member in your practice. It says here from the AUA, advanced practice providers will formulate appropriate clinical management strategies in consultation with a urologist. I do think collaborative practice is where it's at. That's my background. I admire Elise for having her own independent practice. That's appropriate. It fits her style, her interests, her practice. I'm really into a team-based approach. I love being in a collaborative practice with my urologists that I work with, but they also love that I can go and do some things that I don't need their help with, and that's mutual for both of us. So, formal program of training, including didactic curriculum, observation, and skills training. 5 years ago, Tracy Krupski, our vice chair, and one of my colleagues had a tobacco grant where we wanted to look at doing telecystoscopy. We've published about this in far southwest Virginia, where our bladder cancer patients were actually not returning for their surveillance. So we wanted to train the nurse practitioners who ran the health wagon in far southwest Virginia to do cystoscopy, and we viewed those cystoscopies in Charlottesville. One of the components of that grant was, well, we'll need to have APPs who can actually do cystoscopy before we go down there and train some more. So we built a program for education, training, got our APPs credentialed, and then went down and taught other APPs how to do that. But the trial was really not about teaching APPs to do cystoscopy. It was, could you actually successfully use telecystoscopy to identify a tumor? So that was her goal, but the goal was very worthy because in part of that program, we built a training program for training APPs to do cystoscopy. So they add value across the patient experience. This has been well documented. Great track records of cost-effective quality care, increased work group productivity, increased profit margins with higher physician compensation and practice profitability. There has been some literature published about, well, this will hurt my practice as a physician if she is doing, or she or he are doing all the cystoscopies. In fact, many of the studies have looked at this from a business efficiency standpoint and said, in fact, no, your practice will continue to thrive and grow, and this is just a parallel practice to your practice. It will not damage your practice and your profitability. And they can generate a high contribution margin with cystoscopy and actually contribute towards their salary. What about satisfaction? I think this is one of the most important aspects. APT job satisfaction can be achieved with them feeling confident with an increased skill set. Many APPs want to find something else they can do besides the office visit, some procedure that gives them some satisfaction and builds their skill set. Team satisfaction. I'm in an academic healthcare center. Our residents are like, I am just not that interested in removing any more transplant stents. They get to go to the OR. They do cystoscopy in the OR all the time. They do all those fancy things. They're like, I am just not into it. You want to do them all? You take them. So we knew that we could help our resident satisfaction and even our attending surgeon satisfaction. They just said, we are actually not transplant stent removal specialists. We're urologists, and that's not really our only thing we want to be doing in our practice. I'd rather be looking for bladder tumors, or removing stones, or looking in the bladder for getting ready for a TURBT in the OR. So we knew we could help team satisfaction. We have great patient satisfaction. Our Press-Ganey results show us that patients are just as happy with this. There was a study just published, and I heard presented at the Mid-Atlantic by Adele Caruso from Penn, that they were looking at APP fluency with diagnoses. Now, in their study, they let patients choose, do you want to see an APP or an MD? We don't have that option in our system, so you get assigned to whoever sees that diagnosis, and that may be MD or APP. However, in her study, one of the things they found was that if the APP was experienced, was fluent, and able to talk with them about the diagnosis, hematuria, knew the guidelines, knew what workup they needed, could explain this to the patient, get them set up for the next part of the evaluation, patients rated that very high. So we know that it's worth the investment to train your APP or to get them the training they need to be successful, because it will actually enhance your practice and improve satisfaction from the referring physicians. Our transplant team was bearing down on us. We're going to double our transplants this year. Who's going to take out all those stents? We need a plan for that. We developed a plan for that. We developed more procedure time for me to just have nothing but transplant stent removal procedures several days a week. Those clinics are available, and we just crank patients through. As someone said earlier, you don't need to do a lot of teaching of that. You go in, they sign the consent, we get them draped and get them on the table, remove the stent, and send them off to the transplant lab or the transplant clinic. So great satisfaction. Also, it freed up spots for cystoscopy for perhaps an attending to do a cystoscopy for other reasons, not a stent removal. So we know they're cost effective. Studies show that adding it will increase reimbursement for both physicians and APP providers. Office cystoscopy, RVU, is 1.53. I may need to update that. But office cystoscopy with stent removal is 2.79. A level 4 E&M initial visit, or RVUs for physician to see, is only 1.92. So better for me to do the office with stent removal than the level 4. But much more importantly, better for that initial visit that's going to book a cancer surgery to be with the surgeon being evaluated for surgery and someone else being removing a stent. So here's the take-home message: increases overall work group productivity, increases collections and RVUs, increases patient throughput, frees up the time for the urologist to meet that initial visit for surgical consultation, increases job satisfaction and career potential, and is supported by all of our major groups, the AUA, the SUNA, and the American Association of Nurse Practitioners. Thank you.